Welcome back to the Movement PhD. I'm Dustin Hardwick, a physical therapist with a PhD in movement science. Today's episode is the final episode of our lumbar spine unit. Today we will discuss the sacroiliac joint and how common postural and movement faults contribute to pain and dysfunction of the lumbar spine. As usual, you can find the slides in sync with video on YouTube and Spotify. If you're listening to an audio podcast, you can find the slides on my Substack. Now that we have our slides pulled up, let's get started with Season 1, Episode 9, the sacroiliac joint and lumbar movement syndromes. Let us start today with a brief overview of the purpose of that sacroiliac joint, or SI joint for short. It really is a connection between the axial skeleton, so that spine plus that rib cage, with our lower extremity. Because it is a synovial joint and with some ligamentous support, it may allow for some absorption of shock between the lower extremity and the upper extremity. That is particularly evident when there are unilateral forces or twisting motions through that pelvic ring that come up through those lower extremities. So think about sprinting, running, stairs, all these kind of things put twisting or unilateral forces on that pelvic ring. The SI joint may be allowing for some absorption of that energy or some absorption of that shock. There's long been debate about the importance of that SI joint in relation to both lumbopelvic motion and pain in that lumbopelvic area. Proponents argue that the SI joint is a synovial joint with nerves and a vascular supply that are subject to inflammation and degeneration, just like any other synovial joint in the body. So therefore, why is it any different? It can also lead to pain. They also cite the significant movement of the pelvic ring during childbirth as evidence that it's related to that movement as well. The other side states that the magnitude of forces needed to disrupt that strong support, so strong ligamentous support of that SI joint, are really beyond normal forces that are acting on the body during normal movements. Therefore, any SIJ pain is really just referred from the hip or referred from that lower back. Therefore, you get widely varying estimates of SIJ involvement in pain from 10 to 38%. That's a pretty big range of different percentages there. So where do I fall in this debate? I'm right smack in the middle. I think for a lot of individuals, it could be referred pain from lumbar or hip. But for people that have any kind of condition that causes that ligamentous support to be disrupted, so think about childbirth or diseases that involve connective tissue or monthly changes in female, then I think there's a good chance that that SIJ could be involved. So like many things, I fall in the middle. It's not always the most important, but it is an important structure in some cases. Let's go through the structure of that sacroiliac joint. So that SI joint is a weight-bearing compound joint. There's really two joints within that SI joint. There's an anterior synovial joint between the auricular surfaces of the sacrum and that ilium. So that auricular surface of your sacrum is right here. So it's kind of an L-shaped auricular area here. On our ilium, that auricular surface is right here. So this is our auricular surface of our ilium. So that synovial joint is the connection between these two auricular surfaces. So it's a synovial joint. It has a capsule. It has synovial fluid, just like any other synovial joint. On the posterior aspect, there's another posterior syndesmosis between that same sacrum and that same ilium. So that is the less movable syndesmosis joint. SI joint allows for 6 degrees of movement. So there's rotation in all of the cardinal planes. So there is sagittal plane rotation, there's frontal plane rotation, and transverse plane rotation. But there's also translation in those same 3 cardinal planes. So there's sagittal plane translation, there's frontal plane translation, and there's horizontal plane translation as well. So that seems like a lot of degrees of movement. However, the movements typically, so in individuals with normal connective tissue integrity, there's very little movement in any of these different planes. So the estimates vary from 0.4 to 4.3 degrees of rotation in non-weight bearing and almost no motion in weight bearing. As I mentioned earlier, that SI joint functions in weight bearing as a way to transmit forces between that upper extremity, so the axial skeleton plus the upper limbs, with those lower limbs. It's part of this pelvic ring structure, one of the two different joints of the pelvic ring, the pubic symphysis being the other joint within that pelvic ring. So this pelvic ring really transmits forces between the lower extremity and the upper extremity. Because there are two different joints here, they allow for very small amounts of movement, as I mentioned on the previous slide, which may act to dampen some of the shock that is being transmitted from the lower extremity to the upper extremity and vice versa. Let's talk about the two most important movements of that SI joint. That is nutation and counternutation. Now, these are sagittal plane motions since they involve an anterior or a posterior tilt. Nutation occurs when your sacrum rotates or tilts anterior on that ilium, or when that ilium rotates or tilts posterior on that sacrum. So these motions are not mutually exclusive. You can get them occurring at the same time where we have a posterior iliac and an anterior sacral tilt. That is nutation. Counternutation is the opposite of that. In counternutation, you have a posterior tilt of that sacrum or an anterior tilt of that ilium on that sacrum. And again, these things are not mutually exclusive, so you can get a posterior sacral tilt with an anterior iliac tilt. So that is nutation and counternutation. So what are the muscles that contribute to nutation or counternutation? For nutation, that's either going to be activation of your erector spinae, because they're going to pull that sacrum into that anterior tilt. So pull of that erector spinae here is going to tilt that sacrum anterior. Or it's going to be pull on that iliac crest in the posterior direction from biceps femoris and other hamstring muscles. What are the forces that contribute to counternutation? Well, that's primarily going to be your hip flexors, because they're going to be pulling that ilium into that anterior tilt. So normal amounts of nutation and counternutation, that's normal in that pelvic ring because it's there to dissipate forces, to give a little bit of shock absorption. However, when we get to the extremes of motion, so in a limb that's in maximal extension, maximal flexion, and under significant load or significant muscle activation, we can get pelvic torsion, which is excess asymmetrical motion of that SI joint. So when we get that excess asymmetrical motion, that's when pelvic pain types of things happen. So we can either get irritation, that SI joint itself, particularly if there is any kind of ligamentous laxity for whatever reason there may be, whether it's monthly cycle, pregnancy, or any kind of disease that's related to that connective tissue, or it could also cause problems in that pubic symphysis for those same reasons. So normal amounts of motion, that's good. When we get excessive load, excessive muscle activation in a very asymmetrical posture, that's when SI joint pain syndromes typically do occur. We're going to switch gears now and talk about some posture and movement impairments of that lumbar spine. We're going to start with hyperlordosis. So remember, a lordosis, that's normal in the lumbar spine, but when it's exaggerated, now we're in a hyperlordosis or a hyperextended position of that lumbar spine. So it's going to be associated with that anterior pelvic tilt, because remember, anterior pelvic tilt puts that spine in a compensatory extended position. So this hyperlordosis, anterior pelvic tilt, those things are associated. You're going to see some shortness of those hip flexors, shortness of those paraspinals, those abdominal muscles, they're not doing their job. Because of that hyperlordosis of that lumbar spine, you're often going to see that thoracic spine in a hyperkyphosis. So those two things are going to be associated. You also see them standing in some hyperextension of the knees, and that's just because in that hyperlordotic posture, it puts that weight anterior to that knee joint, so it drives those knees into that hyperextended position. We'll talk about some of the associated pathologies and diagnoses in our next slide here. So let's talk about some of those extension syndromes. So extension syndrome just means pathologies associated with too much extension. So that hyperlordotic posture being an example of too much extension. So again, remember, we're going to have shortness of those hip flexors and those lumbar paraspinals, and you're going to see those anterior abdominal muscles, so transversus abdominis, those obliques, maybe even the rectus abdominis, they're going to be relatively weak and not really fulfilling their roles for stability. Because of that, we're going to have overactivation of those lumbar paraspinals. So one pathology is just overactivity strains of the lumbar paraspinal muscles. So let's talk a little bit more about some of those pathological mechanisms. So remember, in extension, we're getting a narrowing of that intervertebral foramen. So that narrowing can put compression pressure on those spinal nerves as they exit. So stenotic or stenosis types of situation here. The other thing that's going to be loaded is those facets, because in extension, those facets are downsliding, which is a compressive force on those facets. So we're going to get an increased loading to those facets. So they're more likely to have degenerative changes, such as a facet joint arthropathy. We're going to get, again, compensatory overactivation of those lumbar paraspinals, so they can cramp, they can get strains, sprains, and other things like that. The other thing is those anterior shear forces are increased. The hyperlordosis increases the anterior shear forces from gravity, and we have shortness of those hip flexors. Remember that psoas major pulls directly to that lumbar spine. So if one of those short hip flexors is psoas major, it's going to contribute directly to the anterior shear forces on that lumbar spine. So spondylolysis, spondylolistheses being pathologies associated with that anterior shear force. So when are they going to get pain? They're going to get pain with standing, because that's an extension posture of that lumbar spine. They're going to get pain with return from forward bending, because they will typically use a lot of lumbar spine extension when they're picking up an object from the floor. In any kind of posture that puts them in extension, that's going to cause pain. So therefore, what are our major treatment goals? So we want to fix those movement impairments. So what are we going to do? We're going to try to lengthen those hip flexors. That's going to get them out of that anterior pelvic tilt. It's going to relieve that extension moment caused by that psoas major. We're going to strengthen those abdominals, particularly that transversus abdominis first, then building those bigger abdominals on top of it. So transversus activation first, then core exercises that activate the rest of those abdominals. That's going to take that stress off of those lumbar paraspinals. It's also going to get them again out of that anterior pelvic tilt and get that spine back to its normal lordotic curvature. We want to fix their posture, so not just fix the muscles, but teach them about postural corrections. And we want to limit them standing. So we want them, if they're doing a job that involves a lot of standing, to take some sitting breaks. So get out of that extension postures when at all possible to relieve stress on whatever that pathology is between the facets, whether it's the nerve itself, that's going to relieve the pressure on them and allow those tissues to heal. Let's talk a little bit about that facet joint arthropathy. Because those facet joints are a synovial joint, a facet joint arthropathy is an example of osteoarthritis. So basically, we get a breakdown of that cartilage faster than we can maintain it, and over time, those degenerative changes cause inflammation, cause impingement of those nerve roots. Most common site, L4, L5, L5, S1. Why those two levels? Because they're the area under the greatest load. Let's talk a little bit about spondies, so spondylolysis and spondylolisthesis. A spondy is a fracture of the pars. So let the words help you here. The full name of the pars is the pars interarticularis. So that word tells you that the pars is the area of bone between the superior and the inferior facet. If you look at an oblique X-ray of the spine, the pars interarticularis is the neckline of that Scotty dog formation of that spine. So if you look at that area, it looks like a dog. the area that the break occurs through that pars is at that neckline. So what's the difference between that spondylolysis and that spondylolisthesis? Well, a spondylolysis is a stress fracture. Spondylolisthesis is a full fracture of that pars. So therefore, with that full fracture, you get an anterior slippage of L4 on L5 or L5 on S1. Now let's talk about the flat back posture. So this is the opposite of that hyperlordosis. Now we have a decrease in that lumbar lordosis. With that, we also have a decrease in that thoracic kyphosis. Therefore, we have a flat back posture because the spine is very flat. So it has a reduction in the curves. So remember, the curves are necessary for absorbing shock from those ground reaction forces when we're walking, taking stairs, when we're running. So when we don't have those curves, as in this flat back posture, now we're taking more of that force and putting it through those intervertebral discs. So with this posture, we have a posterior pelvic tilt. So therefore, the muscles that are going to be shortened are hamstrings, glutes, and abdominals. And those muscles that are lengthened are going to be those paraspinals and those hip flexors. So primary pathologies related to this include discogenic types of things, because now all of those forces that used to be shared by the muscles, by the ligaments, by the facets, now all of that force is going through those intervertebral discs. Let's break down those flexion syndromes a little bit more. So again, we have shortness of those abdominals, those glutes, and those hamstrings, and then we have relatively poor performance of those lumbar extensors and those hip flexors. So what are associated pathologies here? Well, they are discogenic or disc herniation types of things. Because remember, when you are in flexion, that puts compression to that intervertebral disc on the anterior aspect. So therefore, that nucleus within those intervertebral discs is going to be pushed posterior. And that posterior push of that nucleus can eventually wear through those annular rings and cause a bulge or a herniation. We typically see those injuries not just flexion, but flexion with rotation. So in the north, where we have snow, a typical provocation of a disc herniation type of injury is shoveling snow, because it is flexion with rotation, and that rotation is under load. So why rotation? When we have torsion on those intervertebral discs, they tend to put a lot of stress on those fibrocartilaginous rings, and they can start to shred those rings, which then in flexion, that nucleus is going to be more easily pushed through those annular rings. So in these flexion syndromes, pain is going to be worse with sitting, because sitting is typically associated with more of a flexed posture. They're going to get pain with forward bend. And when you watch these individuals do a forward bend, they don't move a whole lot in the pelvis. Most of their forward flexion comes from that lumbar spine. So you'll see excess flexion of that lumbar spine during a forward bend type of maneuver. So lifting objects from the floor is going to be painful. Any kind of position that puts them in lumbar flexion is going to exacerbate those symptoms. So what are our treatment goals for flexion syndromes? The first thing is to get them out of that flexion. So let's think about some postural corrections and some lifting techniques. So when they're sitting, we may have them put a towel roll or a lumbar support behind their lower lumbar spine to just get them out of that excessive flexion posture. We want them to limit sitting. So if they're at a job where they're sitting a lot, I will set a timer on their Apple Watch or whatever. Every 15 minutes, they have to take a few minute standing break just to get them out of that sitting posture. We're going to teach them to lift better. They typically, again, lift with hyperflexion of that lumbar spine. We'll teach them to hinge at the hip. So more of that forward bend comes from the hip and less of it from that lumbar spine. To help us out, we need to increase the length of those hamstrings. So we'll do some hamstring stretches. Again, paying attention to the position that they're in when they're doing that hamstring stretch. So you don't want them to do a hamstring stretch, which increases that lumbar flexion. So thinking of doing your hamstring stretches lying on the floor with a towel under that lumbar spine. We might also lengthen those abdominals by doing some prone on elbows, prone press up types of things. Those also tend to make that disc bulge feel better. So we're going to do extension types of things here. We also want to strengthen those lumbar paraspinals. So we might do some exercises to increase the strength of those lumbar paraspinals, whether it's Superman's, whether it is part of that lifting techniques. So really just working on utilizing those lumbar extensors to maintain that correct posture of that lumbar spine during lifting. So let's talk a little bit about disc herniation, because that's one of the common presentations of these flexion syndromes. It is probably the most common cause of low back pain, especially in younger 30 to 50-year-old populations. Fortunately, most cases heal within 2 to 4 weeks with some rest and modification of activity. However, some people may persist, and those are the patients that we will see in PT and other types of rehab. Again, usually the force that's causing it is flexion, again, because that's going to push that nucleus posterior, and rotation, because torsional forces tend to disrupt those cartilaginous fibers within those intervertebral discs. So again, pathophysiology, mechanical compression, or chemical irritation, either from the nucleus itself or because of that inflammation causing a chemical irritation to that nerve root. Now let's summarize those extension syndromes and those flexion syndromes. So in extension syndromes, they tend to be pathologies like facet joint OA or facet joint arthropathy, because those facets are loaded in extension. So greater the load, the more likely they are to degenerate. Erector spinae strains, because in extension syndromes, they tend to try to stabilize their spine with those erector spinae muscles. Stenosis, because in extension, we're closing off those intervertebral foramen. And then spondylolysis, spondylolisthesis, because extension or hyperlordosis is associated with an increase in those anterior shear forces. Also, shortness of the psoas major could be a direct contributor to that anterior slippage of the L4 on L5 or L5 on S1. Flexion syndromes, these typically are disc involvement. So because we have an increase in that anterior compression of that intervertebral disc, so herniations and bulges are common examples of flexion syndromes. You could also get some posterior ligamentous injuries, so more acute flexion syndromes because of a too much load in flexion, picking up a heavy object. You could pop that interspinous ligament or that supraspinous ligament. So what do we do for these individuals? We typically do motion in the opposite direction to alleviate pain. So for extension syndromes, we want to do flexion types of things. So we want to strengthen the anterior abdominal muscles. We want to get them out of standing and put them in sitting. That's going to typically alleviate the pressure and the stress on those structures that are typically under load during extension. For flexion syndromes, we want to do extension types of things. So Mackenzie extension exercises, so prone on elbows, prone press-ups, all these are going to be examples of extension exercises. And we want to limit their sitting, so they're going to take standing breaks if they're sitting for long periods of time. So what are some of the other differences here? Extension syndromes tend to be older, especially that facet joint OA and that stenosis. Some of the other ones could be any age group. Flexion, they tend to be disc involvement or posterior ligamentous things, so 30 to 50 years of age, 20 to 45, tend to be kind of your typical presentation for flexion syndromes. Again, typical. You can have individuals of all age groups presenting as extension syndromes or flexion syndromes. If you see pain in all directions plus weight bearing, so they have pain with flexion, they have pain with extension, and doing any kind of movement to alleviate it doesn't work, that tends to be a poor prognosis. So if we have pain that's not associated with a direction of movement, that's not a good thing. Finally, let's review the impact of specific postures on different tissues. I think if you can understand this chart, it will really help you understand flexion syndromes and extension syndromes. So take a second to pause the video or go to my Substack and find this slide and really spend some time looking at it. I'm not going to go through the whole chart, but I'm going to pick a few highlights of each. So in flexion, that nucleus is pushed posterior. So that's why we have that association between a flexion syndrome and disc herniation. The posterior ligaments, they're under tension. So if we have a stress type of injury to that posterior longitudinal ligament, ligamentum flavum, interspinous ligament, supraspinous ligament, those can be injuries associated with flexion syndromes, more acute flexion types of syndromes. And the other thing, the spinal cord is under increased tension during flexion. So there's a test for the spinal cord tension called a slump test, which basically you put your spine in full flexion, and that puts tension on that spinal cord. Conversely, the effect of extension, what are things that are under stress? Well, there's maximum compression of those apophyseal joints or those facet joints. So that's why extension is associated with that facet joint arthropathy, with those facet joint types of OA. The intervertebral foramen, that's narrowed in extension. So that's why we have that association of extension syndromes and stenosis, because that's a position of narrowing of those intervertebral foramen. The posterior structures, they're under slack, but the anterior structure, the ALL, that's going to be under some tension. That's a pretty thick and tough ligament, so we usually don't see much in the way of anterior longitudinal ligament injuries. And the spinal cord, that's going to be under decreased tension. The final movement impairment of the lumbar spine is lumbar instability. So in lumbar instability, we have abnormal movement between two or more spinal segments. So you can think about it as intersegmental instability. So there are two major types of lumbar instability. There's our functional instability, which there is nothing wrong on x-rays, on MRIs, so there are no structural defects. What's happening is pain is caused because there's too much movement, because either the neural system, so motor control of those muscles that stabilize the spine, multifidus, transversus abdominis, or the performance of those muscles themselves are interrupted. So it's functional because there are no apparent structural problems. It's just poor performance of those muscles, either coming from the neural system or from the muscular system itself. The other type of instability is a structural or a mechanical instability, which means that there's a disruption of those passive stabilizers. So it could be a defect in the anatomy of the bone. It could be ligamentous instability due to some kind of pathology. So it's a structural instability because it's related to these passive structures, not the active component like in that functional instability. So these two things are not mutually exclusive. You can have a structural instability on top of a functional instability, or that structural instability could cause a functional instability. Either way, we have lumbar instability. So what are some examples? So degenerative changes, so like a spondylolisthesis would be an example of that because you have an anterior slippage of one vertebrae on the other. It could be a congenital problem such as scoliosis, because that's going to cause a structural instability of the spine because now we have a curvature which throws off the stability of the spine. We could have another type of defect like a sacralized L5. So in a sacralized L5, L5 is fused with the sacrum. So if we have L5 fused on S1, now all of that movement that used to occur at L5, S1, now it has to happen at the rest of that lumbar spine. So we're taking that load and putting over a smaller area, so you're more likely to get aberrant movements at L4, L5, because now it has to do the work of both segments. So what's our treatment goals for this lumbar instability? Well, it's stabilization. It doesn't matter whether it's a structural mechanical instability or a functional instability, our treatment goal is still going to be stabilization. So we want to activate those deep stabilizers. So transversus abdominis, multifidus, we want to teach them to do that abdominal bracing. So therefore, we also need that pelvic floor muscles to do their job. We need that diaphragm to do its job as well. Thank you for joining me for this final episode of our lumbar spine unit. Today, we reviewed the sacroiliac joint and how common postural and movement faults contribute to pain and dysfunction. In the next episode, we're going to start our knee unit. with a review of the bony anatomy and arthrokinematics. Thanks again for watching, and I'll see you next time.